Question 1. Trauma emergencies. Blunt versus penetrating trauma. 34-year-old male arrives at the emergency department following motor vehicle collision. He was restrained driver and struck his chest against the steering wheel. Upon assessment, he has significant bruising across his chest, mild respiratory distress, and decreased breath sounds on the left side. His blood pressure is 88/54 Hg, heart rate is 100 EPM, and respiratory rate is 30 BPM. What is the most likely diagnosis and what is the priority intervention? A. Pulmonary contusion. Administer high-flow oxygen and prepare for mechanical ventilation. B. Tension pneumothorax. Perform needle decompression followed by chest tube placement. C. Cardiac tamponade. Initiate pericardiocentesis immediately. D. Flail chest. Provide positive pressure ventilation and consider intubation. Answer B. Tension pneumothorax. Perform needle decompression followed by chest tube placement. Explanation. This patient has signs of tension pneumothorax, a life-threatening condition resulting from blunt chest trauma. Decreased breath sounds on one side. Hypotension and tachycardia indicate compromised ventilation and circulation due to increased intrathoracic pressure. The priority intervention is immediate needle decompression, typically the second intercostal space at the midclavicular line, followed by chest tube insertion to re-expand the lung. Options of pulmonary contusion. Pulmonary contusions present with hypoxia and respiratory distress but do not cause immediate hemodynamic instability or unilateral breath sound loss. Option C. Cardiac tamponade. Beck's triad. Hypotension, distended neck veins, muffled heart sounds would indicate tamponade, but this patient lacks muffled heart sounds. Option D. Flail chest. This occurs when multiple rib fractures cause paradoxical chest movement. However, this patient's primary issue is hemodynamic instability from tension pneumothorax. Question 2. Medical emergencies. Endocrine emergencies. Diabetic ketoacidosis. 19-year-old female with type 1 diabetes mellitus presents to the ED with nausea, vomiting, and abdominal pain. She is lethargic but responsive. Her vital signs are BP 95, 60 mH, DISHA 118 ER at 28 breathmin, and temperature 37.8 deg. Laboratory results reveal blood glucose of 406 mdl, pH of 7.18, bicarbonate of 10 methyl, and positive serum ketone test. What is the most appropriate initial treatment? A. Administer subcutaneous insulin and encourage oral hydration. B. Initiate Roman UIDs with normal saline and store Roman insulin infusion. C. Administer sodium bicarbonate immediately to correct acidosis. D. Provide Roman extras to prevent hypoglycemia. Answer B. Initiate Roman UIDs with normal saline and Roman insulin infusion. Explanation. This patient has diabetic ketoacidosis, DKA, a life-threatening complication of type 1 diabetes characterized by hypoglycemia, metabolic acidosis, and ketosis. The most critical initial treatment is fluid resuscitation with normal saline 0.9% NaCl to correct dehydration, followed by Roman insulin, reduce blood glucose and ketone production. Option subcutaneous insulin and oral hydration. Insufficient Roman insulin is required for rapid correction, and oral hydration is inappropriate due to altered mental status. Option C. Sodium bicarbonate administration. Only indicated if pH is 6.9, as bicarbonate therapy can cause paradoxical worsening of acidosis and electrolyte imbalances. Option D. Roman extras. Dextrose is added after insulin therapy once blood glucose falls to 250 mdl to prevent hypoglycemia, but it is not the initial priority. Guidelines reference. American Diabetes Association ADA 2022 guidelines recommend aggressive Roman resuscitation as the first step in DKA treatment, followed by continued Roman insulin infusion and electrolyte replacement. Question 3. Scenario-based. Emergency procedures and skills. Airway management. Mr. Ramirez, 54-year-old male with history of COPT, presents to the emergency department in acute respiratory distress. He is using accessory muscles, has respiratory rate of 40 breaths per minute, and is unable to speak in full sentences. Arterial blood gas above results show EH 7.28, PAO 65 mHg, and PAO 55 mHg on room air. His mental status is deteriorating, and he is becoming lethargic. What is the best next step in management? A. Apply non-rebreather mask and closely monitor oxygen saturation. B. Initiate non-invasive positive pressure ventilation NIV, such as BiPAP. C. Administer aeroids and nebulized bronchodilators and re-evaluate in 30 minutes. D. Immediately intubate and place on mechanical ventilation. Answer B. Initiate non-invasive positive pressure ventilation (NIV), such as BiPAP. Explanation: this patient has acute hypercapnic respiratory failure due to COPD exacerbation, as evidenced by respiratory acidosis, low pH, elevated parcohypoxia, and deteriorating mental status. Non-invasive ventilation (BiPAP) is the preferred initial intervention as it helps reduce the work of breathing, improve gas exchange, and avoid intubation-related complications. Option: non-rebreather mask only, insufficient for severe hypercapnia. The BiPAP provides both oxygenation and ventilation support. Option C: steroids and nebulizers alone. While bronchodilators and corticosteroids are essential, they do not provide immediate ventilatory support. Option D: immediate intubation, indicated if BiPAP fails or if the patient shows impending respiratory arrest, severe lethargy, inability to protect airway. Guidelines reference: the Global Initiative for Chronic Obstructive Lung Disease. GOLD guidelines recommend NIP as first-line therapy for acute COPD exacerbations with hypercapnic respiratory failure unless there are absolute contraindications, e.g., inability to protect the airways, acidosis, or hemodynamic instability. Question 4. Trauma management in a multi-victim accident. A multi-vehicle collision occurs on a highway and you are the triage nurse on duty. There are 5 victims with various injuries. Victim A: unconscious, shallow breathing, weak pulse. Victim B: awake, severe leg deformity, bleeding from a laceration. Victim C: complains of severe abdominal pain, signs of shock. Victim D: walking around, minor abrasions, disoriented. Victim E: breathing, no pulse. Using the START triage system, which of the following represents the most appropriate prioritization of care? Victim were immediate, victim B delayed, victim C immediate, victim D minor, victim E deceased. B: victim immediate, victim B immediate, victim C immediate, victim D delayed, victim E deceased. C: victim delayed, victim B immediate, victim C immediate, victim D minor, victim E immediate. D: victim deceased, victim B delayed, victim C immediate, victim D minor, victim E immediate. Answer A: victim immediate, victim B delayed, victim C immediate, victim D minor, victim E deceased. Explanation: the START triage system, simple triage and rapid treatment, is used to quickly categorize patients in mass casualty incidents. Immediate red, life-threatening but potentially survivable injuries. Delayed yellow, serious but not immediately life-threatening. Minor green, walking wounded, minor injuries. Deceased black, no signs of life. A victim is immediate due to unconsciousness and weak pulse. A victim B is delayed because of a severe leg deformity and controlled bleeding. Victim C is immediate due to signs of shock. Victim D is minor, able to walk. Victim E is deceased, no breathing, no pulse. This aligns with START triage protocols and emergency disaster management guidelines. Question 5. Managing a pediatric respiratory emergency. A 4-year-old child is brought into the emergency department by their parents, who report worsening difficulty in breathing over the past 2 days. Upon assessment, you observe the following: high-pitched inspiratory stridor, barking cough, low-grade fever, increased work of breathing. Which of the following interventions should be avoided in managing this patient? A. Providing humidified oxygen therapy. B. Keeping the child as calm as possible. C. Performing direct throat inspection with a tongue depressor. D. Administering nebulized epinephrine. Answer: C. Performing direct throat inspection with a tongue depressor. Explanation: the child's symptoms suggest croup, laryngotrachobronchitis, a common viral respiratory infection in young children. Croup causes airway inflammation, leading to stridor, a barking cough, and respiratory distress. A. Providing humidified oxygen therapy is correct because warm, humidified air can help ease airway swelling. B. Keeping the child calm is critical as agitation can worsen airway obstruction. C. Performing direct throat inspection with a tongue depressor is dangerous because it can trigger laryngospasm, leading to complete airway obstruction. D. Nebulized epinephrine is an appropriate treatment for moderate to severe cases of croup to airway swelling. This follows American Academy of Pediatrics and Pediatric Advanced Life Support (PALS) guidelines for croup management. Question 6. Ethical dilemma in emergency nursing. A 65-year-old unconscious patient arrives in the emergency department after a motor vehicle accident. The patient has Do not resuscitate DNR order documented in their medical record, but the patient's family is demanding full resuscitation measures, stating they changed their mind last week but never updated the paperwork. What is the most appropriate course of action? A. Respect the written DNR order and withhold resuscitation efforts. B. Immediately begin CPR since the family is insisting. C. Contact the hospital ethics committee before taking any action. D. Initiate a time-limited trial of resuscitation while clarifying the patient's most recent wishes. Answer A. Respect the written DNR order and withhold resuscitation efforts. Explanation. Emergency nurses must follow legal and ethical guidelines regarding advance directives. A order is a legally binding document unless properly revoked by the patient. A. Respecting the written DNR order is the correct response based on EMTALA regulations and state advance directive laws. B. Performing CPR despite a valid DNR order would be legally and ethically inappropriate unless there is documented revocation by the patient. C. Contacting an ethics committee may be helpful later, but immediate action is needed in an emergency. D. A time-limited trial is not appropriate because there is legal directive against resuscitation. This follows American Nurses Association Honor and Emergency Medicine Ethical Guidelines. Question 7. Hemorrhagic shock management. A trauma patient presents with the following: blood pressure 78/58 G, heart rate 135 bpm, cold clammy skin, weak peripheral pulses, decreased urine output. Which of the following is the priority intervention? A. Administer 2 liters of normal saline rapidly. B. Start vasopressor medications immediately. C. Initiate massive transfusion protocol. D. Position the patient in Trendelenburg position. Answer C. Initiate massive transfusion protocol. Explanation. The patient is in Roman hemorrhagic shock requiring rapid blood product administration. A. Normal saline can temporarily improve perfusion but does not replace lost oxygen carrying capacity. B. Vasopressors should not be first-line treatment for hemorrhagic shock. C. Massive transfusion protocol 1:1 ratio of plasma, platelets, and RECS is the correct answer to restore oxygen delivery and prevent coagulopathy. D. Trendelenburg position is outdated and not recommended. This follows Advanced Trauma Support ASOPS and American College of Surgeons Act guidelines. Question 8. Airway management in a burned patient. A firefighter is brought in with severe facial burns, singed nasal hairs, and hoarseness. What is the best immediate action? A. Perform a full-body burn assessment before proceeding. B. Prepare for immediate endotracheal intubation. C. Administer high-flow oxygen and reassess in 30 minutes. D. Styromanuids and pain management before assessing the airway. Answer B. Prepare for immediate endotracheal intubation. Explanation. Airway burns can rapidly progress to complete obstruction. A full-body assessment is important, but airway takes priority. B. Hoarseness and singed nasal hairs indicate impending airway compromise, so immediate intubation is needed. C. Waiting 30 minutes could lead to total airway closure. Aromatid are important but secondary to securing the airway. Following American Burn Association, ABAP, and ATL's airway management protocols. Question 9. Stroke management and time-sensitive treatment. A 58-year-old male presents with left-sided weakness and slurred speech that began 2 hours ago. CT scan shows no hemorrhage. What is the best treatment? A. Administer aspirin and monitor. B. Styromin and heparin drip. C. Administer EPA, alteplase immediately. D. Schedule an MRI to confirm the diagnosis. Answer C. Administer EPA, alteplase immediately. Explanation. TPA must be given within 4.5 hours of symptom onset for ischemic stroke. Aspirin is used for non-EPA candidates. Heparin is not first-line stroke treatment. MRI takes too long and delays treatment. This follows American Stroke Association, ASAP, and AHA stroke guidelines. Question 10. Managing an acute myocardial infarction, STEMI, a 55-year-old male presents to the emergency department with crushing substernal chest pain radiating to his left arm. He is diaphoretic, pale, and nauseous. Vital signs. BP 159H, Dishar Sente ERA 18, SPO 96%. X and segment elevations, Roman terminal, and F. Troponin levels. Elevated. What is the next best step in managing this patient? A. Styromin heparin and schedule coronary angiogram for the next available time slot. B. Administer aspirin, nitroglycerin, heparin, and prepare for immediate PCI. C. Give morphine, beta blockers, and observe for improvement. D. Administer thrombolytics since PCI is not available immediately. Answer B. Administer aspirin, nitroglycerin, heparin, and prepare for immediate PCI. Explanation: the patient is experiencing elevation myocardial infarction STEMI requiring emergency percutaneous coronary intervention ECI within 90 minutes. A. Delaying PCI is inappropriate. B. Administering aspirin, nitroglycerin, and heparin while preparing for immediate PCI is the correct choice. C. Beta blockers are useful but do not replace PCI. D. Thrombolytics are only used when PCI is unavailable within 120 minutes. This follows American College of Cardiology (AC) and AHA-STEMI guidelines. Question 11. Pediatric sepsis and fluid resuscitation. The 3-year-old girl presents to the emergency department with high fever 103.2 to 39.6 tachycardia HR 180 BPM, hypertension BP 68 30 AG, delayed capillary refill. Lethargy, cool extremities, decreased urine output. What is the most important initial intervention? A. Administer imecagioman rueolus of normal saline. B. Start dopamine to increase blood pressure. C. Give antipyretics and wait for lab results. D. Order blood cultures and wait before giving fluids. Answer A. Administer imemcajumanu of normal saline. Explanation: the child is in septic shock requiring rapid fluid resuscitation. A. Imecajumanu is the standard first-line therapy in pediatric sepsis. B. Vasopressors like dopamine should only be started if fluids do not restore perfusion. C. Fever control is secondary to resuscitation. D. Waiting to confirm infection before treating shock is dangerous. This follows Pediatric Advanced Life Support (PALS) guidelines. Question 12. Stroke triage and decision-making. A 72-year-old female is found unresponsive with right-sided weakness and slurred speech. EMS reports symptom onset 3.5 hours ago. CT scan shows no hemorrhage. What is the most appropriate treatment? A. Administer Romi-PA, also place immediately. B. Start dual antiplatelet therapy with aspirin and clopidogrel. C. Perform a carotid ultrasound before deciding on treatment. D. Prepare for emergent mechanical thrombectomy. Answer A. Administer Romi-PA, alteplase immediately. Explanation: the patient is within the 4.5-hour window for thrombolysis to PA. Omi-PA is the best choice for eligible ischemic stroke patients. B. Antiplatelets are given later but do not replace to PA. C. Carotid imaging is useful but should not delay thrombolysis. D. Thrombectomy is only for large vessel occlusions. This follows American Stroke Association (ASAP) and AHA guidelines. Question 13. Managing a tension pneumothorax. A trauma patient presents with severe dyspnea, absent breath sounds on the right, distended neck veins, tracheal deviation to the left, hypotension. What is the most critical immediate intervention? A. Obtain a chest X-ray before proceeding. B. Perform needle decompression in the second intercostal space. C. Start high-flow oxygen and prepare for intubation. D. Give Romanuids and reassess vitals. Answer B. Perform needle decompression in the second intercostal space. Explanation: this is a tension pneumothorax, a life-threatening condition requiring immediate needle decompression. A. Waiting for an X-ray wastes critical time. B. Needle decompression relieves the pressure and prevents cardiovascular collapse. C. Oxygen is helpful but does not resolve the problem. Romanuids will not fix the underlying cause. Following ATLS and emergency trauma protocols. Question 14. Anaphylactic shock management. A 40-year-old with a peanut allergy suddenly develops wheezing, stridor, hypotension, a P70-48G facial swelling. What is the first-line treatment? A. Administer epinephrine immediately. B. Give Roman antihistamines and steroids. C. Provide oxygen and albuterol nebulizers. D. To Romanuids before deciding on epinephrine. Answer A. Administer epinephrine immediately. Explanation: anaphylaxis is treated with intramuscular epinephrine 0.3 mg immediately. B, C, and D are supportive but do not replace epinephrine. This follows American Academy of Allergy, Asthma and Immunology (AAI) guidelines. Question 15. Diabetic ketoacidosis DKA management. A 16-year-old with type 1 diabetes presents with severe dehydration, cuspable breathing, fruity breath odor, glucose, 500 AMD AL, 7.1 ICHIA, 10 methyl gap, 22. What is the most important initial intervention? A. Star Roman normal saline bolus. B. Give Roman or insulin immediately. C. Administer ammonia carbonate for acidosis. D. Order an arterial blood gas AMG before treating. Answer A. To Roman normal saline bolus. Explanation. The priority is fluid resuscitation to correct dehydration before starting insulin. B. Insulin is started after fluids. C. Bicarbonate is not recommended unless pH is 6.9. D. ABs are useful but should not delay fluids. Following American Diabetes Association AID guidelines. Question 16. Seizure management in status epilepticus. A 28-year-old male is actively seizing for 6 minutes. What is the first-line treatment? Romanores Bamasivan 4mg romifenatine immediately. C. Restrain the patient and wait for seizure to stop. D. Order an EEG before giving medications. Answer. Romanores Bamasivan 4mg. Explanation. Benzodiazepines Morazepam diazepam are first-line drugs for status epilepticus. B. Phenytoin is used for long-term seizure control. C. Restraining the patient is dangerous. D. EEG is not required before treatment. Following American Epilepsy Society AES guidelines. Question 17. Acute respiratory distress syndrome ARDS management. A 60-year-old male with a history of COPD was admitted for severe pneumonia. Over the past 24 hours, he developed worsening hypoxia despite high-flow oxygen, respiratory rate, 32 breath-min, power-FIO ratio, 120 mHg. The lateral lung infiltrates on chest X-ray. What is the next best step in management? A. Initiate low-tidal volume mechanical ventilation, CAGIB. B. Administer ammonia aeroids to reduce lung inflammation. C. Increase FIO to 100% and wait for improvement. D. Perform immediate intubation with high tidal volume ventilation. Answer A. Initiate low tidal volume mechanical ventilation, CAGBIB. Explanation. The patient has ARDS power-FIO ratio 200 plus bilateral infiltrates. The best management includes low tidal volume CAGBIB to reduce ventilator-induced lung injury, peak to prevent alveolar collapse, conservative fluid management. Steroids, B, are only used in late-stage ARDS, and C, FIO 100% increases oxygen toxicity risk. D, high tidal volume worsens lung injury. Question 18. Cardiac tamponade in trauma. A 25-year-old male is brought to the ER after a stab wound to the chest. He is hypotensive, BP 80-48, G, achycardic, HR 120 BPM, distended neck veins, muffled heart sounds, pulsus paradoxus. What is the most appropriate next step? A. Perform emergent pericardiocentesis. B. Order an echocardiogram before proceeding. C. Give Roman fluids and monitor vitals. D. Administer thrombolytics for suspected P. Answer A. Perform emergent pericardiocentesis. Explanation. This patient has Beck's-Tribe, hypotension and JVD, muffled heart sounds indicating cardiac tamponade. Immediate pericardiocentesis is life-saving. B. Echocardiogram can confirm the diagnosis but should not delay treatment. Iromanids may help, but definitive treatment is pericardiocentesis. D. Thrombolytics are contraindicated in trauma. This follows Advanced Trauma Life Support (ATLS) guidelines. Question 19. Pulmonary embolism in a post-surgical patient. A 52-year-old female post-op from a hip replacement presents with sudden onset dyspnea, pleuritic chest pain, tachycardia, HR 110 BPM, OSAT 88% on room air, D-dimer, elevated. What is the most appropriate next step here? Order CT, pulmonary angiogram to PA. B. Start empiric anticoagulation with heparin before imaging. C. Perform bedside ultrasound of the legs. D. Obtain an echocardiogram to assess right ventricular function. Answer A. Order A. Pulmonary angiogram to PA. Explanation. The patient is at high risk for pulmonary embolism. P. Due to recent surgery and symptoms. The CT pulmonary angiogram to PA is the gold standard for diagnosing P. B. Empiric anticoagulation is given only if imaging is delayed in high-risk cases. C. DVT ultrasound is useful but does not confirm P. D. Echocardiogram helps assess RV strain but does not diagnose P. This follows an ESC-P guidelines. Question 20. Hyperkalemia with ECG changes. A 70-year-old male with end-stage renal disease, ESID, presents with muscle weakness, bradycardia, HR 45 BPM, ECG peak T waves, widened RS, potassium 7.2 Meckel. What is the most critical initial treatment? A. Administer calcium gluconate. B. Give Romana insulin and glucose. C. Start dialysis immediately. D. Give oral sodium polystyrene sulfonate K-oxalate. Answer A. Administer Romana calcium gluconate. Explanation. This is life-threatening hyperkalemia. Romana calcium gluconate stabilizes the cardiac membrane to prevent arrhythmias. B. Insulin plus glucose shifts K into cells but does not work immediately. C. Dialysis is definitive but takes time to range. D. K-oxalate works slowly and is not suitable for acute management. Following Ackel's guidelines for hyperkalemia. Question 21. Acute aortic dissection. A 65-year-old male with hypertension presents with sudden onset, tearing and chest pain radiating to the back, unequal blood pressures in both Rs, CSR, widened mediastinum. What is the most appropriate next step? A. Perform an urgent CT angiogram of the chest. B. Steroid nitroglycerin for pain control. C. Give thrombolytics for suspected MI. D. Order a chest X-ray before proceeding. Answer A. Perform an urgent CT angiogram of the chest. Explanation. The best initial test for suspected aortic dissection is CT angiography. B. Nitroglycerin is not first-line treatment. C. Thrombolytics are contraindicated in dissection. D. Chest X-ray may show a widened mediastinum but is not diagnostic. Following our aortic dissection guidelines. Question 22. Acute meningitis in an immunocompromised patient. A 35-year-old Hi-positive male presents with fever, headache, neck stiffness, confusion and photophobia. What is the most appropriate next step? A. Toromna ceftriaxone, vancomycin, and ampicillin. B. Perform a lumbar puncture immediately. C. Obtain achenia of the head first. D. Administer steroids before antibiotics. Answer C. Obtain achenia of the head first. Explanation. In immunocompromised patients, always perform achenia before LP to rule out increased intracranial pressure. Empiric antibiotics are given after CT scan. B. LP is done after ruling out. D. Steroids are only given in suspected bacterial meningitis after antibiotics. Following its meningitis guidelines. Question 23. Hypovolemic shock from guide bleed. A 45-year-old male presents with massive hemipnesis, tachycardia, HR 130 EM, hypotension, a PAT 50 mHg. What is the first-line intervention? A. Tight Romanuids and trans-ECS. B. Perform emergent upper endoscopy. C. Give Romanorotine pump inhibitors. D. Administer octreotide for varus or bleeding. Answer A. To Romanuids and trans-ECS. Explanation. The patient is in hypovolemic shock from guide bleeding. Romanuids and blood transfusion are priority. B. Endoscopy is performed once stable. C. PPIs helper not first line. D. Octreotide is for varus or bleeding but does not replace resuscitation. Following guide bleeding guidelines. Question 24. Septic shock management. A 56-year-old female with type 2 diabetes and urinary tract infection (UT) is admitted with severe hypotension EP 75 50 mHg despite adequate fluid resuscitation, tachycardia, HR 130 EPM, fever 102 degrees, and altered mental status, lactic acid level 4.5 mol, elevated B 18,000 till elevated. What is the most appropriate next step in management? A. Initiate broad-spectrum antibiotics, Romanuids. B. Administer vasopressors, e.g. norepinephrine to maintain MAPS 65 mHg. C. Start steroid therapy for presumed adrenal insufficiency. D. Begin insulin therapy to lower blood glucose. Answer B. Administer vasopressors, e.g. norepinephrine to maintain MAPS 65 mHg. Explanation. This patient is in septic shock, persistent hypotension despite fluid resuscitation, lactic acidosis, and infection. B. Vasopressors, norepinephrine, are first line for maintaining MAPS 65 mHg in septic shock after fluid resuscitation. Antibiotics should be started after obtaining cultures but are not the immediate priority in this case. C. Steroid therapy is not indicated unless there is evidence of adrenal insufficiency or refractory shock. D. Insulin therapy is not first line for managing septic shock. Question 25. Acute stroke in the head. A 72-year-old male with a history of hypertension and atrial fibrillation presents with sudden onset left-sided weakness, aphasia, and right-sided facial droop, blood pressure 109 to 100 mHg, pulse 120 EPET, head No acute hemorrhage. What is the most appropriate next step in management? A. Administer intravenous EPA, alteplase. B. Perform carotid Doppler ultrasound to assess for stenosis. C. Start aspirin and clopidogrel for dual antiplatelet therapy. D. Consult neurology for evaluation of mechanical thrombectomy. Answer A. Administer intravenous TPA, alteplase. Explanation. This patient presents with signs and symptoms of an acute ischemic stroke. Given the absence of hemorrhage on CT and the time window, within 4.5 hours, intravenous TPA, alteplase is the most appropriate treatment. B. Carotid Doppler ultrasound is important for chronic evaluation of stroke risk but does not change the acute management. C. Antiplatelet therapy is used in secondary prevention, not for acute ischemic stroke. D. Mechanical thrombectomy is an option for large vessel occlusion strokes, but EPA is the initial step if within the time window. Question 26. Acute myocardial infarction with heart failure. A 63-year-old male with chronic hypertension, diabetes, and hyperlipidemia presents with severe retrosternal chest pain radiating to the left arm, dyspnea and orthopnea EP. 90 if edge tissue 110 EM X elevation neurotonin duff troponin elevated. What is the most appropriate next step in management? A. Administer aspirin, nitroglycerin, and morphine. B. Initiate intravenous heparin and consult cardiology for angiography. C. Give Roman uids and administer furosemide for heart failure. D. Perform immediate percutaneous coronary intervention EC. Answer D. Perform immediate percutaneous coronary intervention ECI. Explanation. This patient is presenting with a St. elevation myocardial infarction STEMI with signs of acute heart failure. The best initial management is immediate percutaneous coronary intervention PCI, as it is the most effective treatment for STEMI to restore coronary perfusion and reduce mortality. Aspirin, nitroglycerin, and morphine are supportive but not definitive for STEMI. B. Heparin is part of the treatment regimen, but PCI should not be delayed for angiography. Romanuids and furosemide would worsen the heart failure and delay reperfusion therapy. Question 27. Anaphylactic reaction in the ED. A 28-year-old female presents with swelling of the lips, tongue, and difficulty breathing. History of shellfish allergy. 8 shellfish 30 minutes ago. BP 90, 6 to mesh tissue 110 EPM. Oxygen saturation 92% on room air. What is the most appropriate next step in management? A. Administer intramuscular epinephrine immediately. B. Give romanephrine, hydramine, and romaneroids. C. Intubate immediately and administer high-dose corticosteroids. D. Begin intravenous fluids to support circulation. Answer A. Explanation. This patient is experiencing an anaphylactic reaction. The first-line treatment is intramuscular epinephrine. A. Epinephrine is the most effective and life-saving treatment for anaphylaxis. B. Diphenhydramine and steroids are adjunctive treatments but are not first-line. C. Intubation is only indicated if the airway is obstructed or if there is respiratory failure. Roman uids may be necessary but are secondary to epinephrine administration. Question 28. Asthma exacerbation in the ED. A 15-year-old male with a history of asthma presents with wheezing, shortness of breath, and increased work of breathing. Oxygen saturation 89% on room air. Respiratory rate 28 breaths min. PEFA 40% of predicted. What is the most appropriate next step in management? A. Administer nebulized albuterol and ipratropium. B. Taromony corticosteroids immediately. C. Provide supplemental oxygen. D. Initiate mechanical ventilation. Answer A. Administer nebulized albuterol and ipratropium. Explanation. This patient is having an acute asthma exacerbation. The best initial management includes nebulized albuterol and ipratropium to relieve bronchospasm. Romanocorticosteroids should be started if the exacerbation is moderate to severe but are not the first intervention. C. Oxygen supplementation is important but should follow bronchodilator therapy. D. Mechanical ventilation is only considered if the patient is in respiratory failure. Question 29. Diabetic ketoacidosis DKA in the ED. A 24-year-old female with type 1 diabetes presents with severe nausea, vomiting, and abdominal pain. Blood glucose 500 for 50 AL, 7.15 bicarbonate, 12 mecal, cosmal respirations, and fruity odor to breath. What is the most appropriate next step in management? A. Administer intravenous insulin and fluids. B. Give subcutaneous insulin and oral fluids. C. Stearomonocarbonate. D. Begin intravenous morphine for pain control. Answer A. Administer intravenous insulin and fluids. Explanation. This patient is in diabetic ketoacidosis (DKA), which require ominoinsulin and fluids to correct the acidosis and hypoglycemia. Ominoinsulin and fluids are the most important components of DKA management. B. Subcutaneous insulin is inappropriate for an acute DKA episode. C. Bicarbonate is rarely needed unless the pH is extremely low, 6.9. D. Morphine is not indicated unless the patient is in severe pain. Question 30. Sepsis with multi-organ dysfunction syndrome (MODS), a 72-year-old female with a history of chronic kidney disease and pneumonia presents with fever 102 deg, hypotension EP80, 50 mHg, oliguria and confusion, lactic acidosis, 6.2 ml. What is the most appropriate initial step in management? A. Start broad-spectrum antibiotics and initiate vasopressors. B. Administer fluids and monitor urine output. C. Give high-dose corticosteroids for septic shock. D. Perform CT scan to assess for abscess or source of infection. Answer A. Start broad-spectrum antibiotics and initiate vasopressors. Explanation. This patient is in sepsis with multi-organ dysfunction syndrome (MODS). The priority is to start broad-spectrum antibiotics and initiate vasopressors for shock. A. Broad-spectrum antibiotics and vasopressors are the first-line treatment for sepsis and septic shock. B. Fluids should be given, but vasopressors are required for hypotension despite fluids. C. Corticosteroids are only used if the patient has refractory shock or adrenal insufficiency. D. Imaging studies may be helpful, but antibiotics and resuscitation are the immediate priority.